G'day, my name is Dr. William Zhou. I am one of the anaesthetic doctors from St George Hospital in Sydney, Australia. Today I'd like to present a hip fracture quality improvement project we've been working on locally. Multiple times a day in Australian hospitals, elderly patients come out of theatre after having their hip fracture fixed, and someone has to decide how to best manage their pain. The guidance on this is unambiguous. Locally, the Australian and New Zealand College of Anaesthetists recommends avoiding long-acting opioids for acute pain, while internationally, the European Prospect Working Group recommends opioids as rescue therapy only. Indeed, there is no strong evidence supporting the use of long-acting opioids in this context, especially in a population that's elderly, that's comorbid, and leads to a significant risk profile. At our hospital, we had no local clinical business rule governing postoperative pain prescribing, and we had no knowledge of what our prescribing practices actually were. As such, we launched a retrospective cohort study at St George Hospital, which is a 600-bed tertiary trauma centre in metropolitan Sydney that covered 141 surgical hip fractures over 12 months. The study explored our prescribing habits and if it matched the evidence. A major finding was that 38% of opioid-naive patients were started on new long-acting opioids after surgery, which was a clear departure from both local and international guidelines. Of those, Targin, a combination of sustained-release oxycodone and naloxone, was the favoured long-acting opioid, accounting for more than 70% of new prescriptions. In addition, we found that more than 90% of patients were prescribed regular paracetamol and as-needed short-acting opioids. We then logically asked, would starting a long-acting opioid actually reduce the amount of short-acting opioid use? What we actually found was that there was no statistical difference in short-acting opioid consumption across any of the first 3 postoperative days between those tried long-acting opioids and those not. We then looked at pain scores, and we found that patients on long-acting opioids were statistically more likely to experience pain on days 1 and 3. But we recognise this is observational data. We can't draw causative conclusions, and these findings are likely confounded by long-acting opioids being prescribed for patients with higher than anticipated pain needs. For us, this is a hypothesis-generating QI project. Our next steps are to identify exactly why prescribers are choosing long-acting opioids and to develop a local clinical business rule to change our local practice. Thank you for your time. I'm looking forward to meeting you all soon.